Hello, another MLA presentation. So this is confusion. So a lot of this will be covered in higher disorders of consciousness, dementias, delirium, but there is a point on your MLA summary list, so I'm going to go through it at least briefly. So we'll talk about what confusion is, how to assess it, the differentials of confusion, the causes, and how to do some tests and manage it. So confusion as a presentation in GP practices in the hospital is really common. Think of it as an acute cognitive issue, and people are often disorientated, they've got inattention, they might have trouble making decisions, or their behaviour might be altered. I've used the word protean there, so many causes, far more than we can go through in a 10-minute presentation. But it's good to have a structure in your mind of how to approach a patient with acute or possibly chronic with an acute exacerbation of confusion. If people are confused, you might be told that their behaviour is altered. They also have hallucinations, delusions, or misperceptions. So if you have a patient and they are reported to be confused, try and establish whether this is entirely new, whether they had any problems before, or whether this is sort of a hyperacute onset. So did it just happen just like that? Is it progressive? Have they been having maybe months, weeks, even years of worsening confusion? And then what has changed if that's the case? So in people who have progressive memory loss, they may have a crisis that's precipitated by, for example, the death of the spouse, and suddenly it becomes clear that they're unable to look after themselves. Or they may have a shift in location. So even coming into hospital for a routine appointment, it can uncover when they're taken away from their usual routine that they're cognitively quite impaired. Is there a precipitant? Do they have an infection? Have they had a head injury? Are they constipated? When you examine someone with confusion, and that can be challenging because they may not wish to cooperate, or they might not understand what they're doing, they might be afraid. So you need to have good communication, you need to be reassuring, you might have to adapt your examination. But look for things like signs of infection. Is there focal neurology? Do they have a temperature? Do they have any focal weakness? And although it can be difficult, try and have some form of objective description of the confusion. So I might be asked to see a patient who's been on the ward for 3 weeks, and every day it's just a bit more muddled, can't examine, bit more muddled, maybe better than yesterday, maybe worse than yesterday, and you just can't do anything with that. So you can do cognitive tests to try and get a number, which can be helpful. But if that's not possible, or the patient can't or won't cooperate, then try and at least have a good detailed description of what the patient can and can't do, the sort of things they're saying, and why you're concerned about the confusion. So differentials. So delirium generally is what we mean when we talk about confusion. It's like an acute fluctuating presentation. People might be quite orientated one moment and quite distressed and disorientated the next. There might be a precipitant like head injury or infection, and there may be a vulnerability underlying which is known, such as cognitive impairment, Alzheimer's disease, Parkinson's disease, or it might be unknown but nevertheless there, and you might uncover through collateral history that there's been some underlying changes that has then been sort of revealed by maybe an infection or something, or coming into hospital. People can be hypoactive, so quite drowsy and difficult to rouse, or they can be hyperactive, that's hyperactive delirium, quite agitated, maybe pacing around the ward trying to escape. Memory, orientation and attention are involved. So these people clearly can't focus on anything. If you ask them a question, they'll drift off. And then there's usually some reversibility if you treat any underlying precipitating cause, which is generally infection we tend to think of. And in dementia, it is a progressive disorder of cognitive function. Memory is often involved first, and I'll be specific, that's usually with Alzheimer's dementia. Okay. Consciousness is clear, so people aren't sort of drowsy or disorientated, at least at first. So they're alert and they're aware, but they may be muddled and they may have amnestic or memory problems. And this can be worsened by delirium, and you may realise that somebody has an underlying dementia for the first time if they have a delirium that brings them into hospital. Now, depression is often cited as something that can mimic delirium or mimic dementia, but it certainly can worsen it. And we call this pseudo-dementia, so it's important to screen for. So in terms of actual things that can cause confusion, so drugs of many, many kinds can worsen confusion. And this may be, sort of strong painkillers after surgery, opioids particularly. That can also cause constipation, which is another precipitant. They could also be drugs of abuse. So cocaine notoriously can make people confused, agitated. Toxins can cause confusion and disorientation. Things like carbon monoxide are well known. Hepatic or renal failure, so accumulation of waste in the body, essentially can make people encephalopathic, drowsy and confused. CO2 retention, so in type 2 respiratory failure, people become drowsy and sometimes quite agitated. If they have a background of COPD, it's quite important to try and get an assessment of their CO2 status. It's usually by an ABG, but that can be tricky if the patient's distressed. Electrolyte disturbance can be in the context of other things like infection or sepsis. Remember, you can have direct infection of the central nervous system like encephalitis, or even just a chest infection or a severe cellulitis, particularly in a vulnerable patient, can make people confused and delirious. ITU delirium is very common, particularly if patients are very unwell. They'll be on lots and lots of drugs, both sedative and they'll be on various relaxants. That can make people very disorientated, and that can be seen in younger people as well as older people, particularly if they come into ITU with something like a head injury. People can be confused if they have nutritional deficit. Again, that's something we see in the vulnerable elderly, or cerebral injury, and that can be something like an acute stroke, lots of falls leading to a chronic subdural, which we see here in the picture. So tests. So you need to tailor test to history, examination and presentation. You need to do what's possible and what's safe, and you need to adapt, particularly for history and examination. Assess the behaviour, describe what the problem is. So sometimes it's much more helpful to say the patient was wandering in a state of undress around the ward and attacking the nurses because they thought that they were trying to burgle them. That kind of captures the situation quite well, as opposed to the patient is muddled. That's not really helpful. You do cognitive testing if it's tolerated, something like, depends on what you use in your area or in your country. We like the MOCA, the Montreal Cognitive Assessment, and it may be helpful if they have something like a head injury or encephalitis to do serial MOCAs to see if there's a trend of improvement or at least stability. And collateral histories are hugely valuable in confusion. The patient quite often doesn't have insight and will say they're absolutely fine and there's been nothing wrong. And then family members will say, well, they'd be progressively confused for months, refused to see a doctor, and then they developed a chest infection, and then suddenly everything's just gone off a cliff in terms of severity. Very helpful. So baseline blood's looking for any obvious nutritional deficiency or electrolyte disturbance, infection markers. Specialist bloods, that really depends on context. So, if somebody has vulnerabilities, something like bloodborne viruses and things, you can do that, or syphilis. Cerebral imaging, especially if things are hyperacute, you think about things like stroke or head injury, or if they have fibromyalgia, it's very important to do some brain imaging. It could also show in the context of chronic impairment, some atrophy, which can be suggestive of dementia, but remember, dementia cannot be diagnosed by a scan, or it could be something like a tumour, which can mimic certain dementia states, but you would tend to see fibromyalgia and or seizures. So confusion is really common. There's a very, very wide range of causes, but the basic structure of assessment, of collateral history, of basic examination, and being able to adapt your examination to what the patient can tolerate is important. You can diagnose several things. So you might diagnose that somebody has a delirium on the background of a pneumonia, on the background of a probable dementia, which is undiagnosed, for example. The borderland between delirium and dementia is porous. So it's sometimes quite hard to know when a delirium ends and a dementia begins. So we often agree to see people in clinic to assess for memory problems after they have a period to improve from their possible delirium. And people can improve very slowly from delirium, particularly if they have underlying vulnerability like Parkinson's or Alzheimer's disease. Thank you.